So the reason to include and actually focus on women and heart disease is that since 1984, certainly in the US, and I believe I've seen European data, women now are the majority of victims of cardiovascular disease. So we have 2 women dying for every man now, and we believe that this is the result of a lack of attention to understanding sex and gender differences, and to not being able to deploy personalized medicine that would be relevant for women. So we have had continuous National Institutes of Health, National Heart, Lung, and Blood Institute funding for our Women's Ischemia Syndrome evaluation. The acronym is WISE. And we think that we have made very good progress. We've worked with an interdisciplinary group across a wide variety of ischemic heart disease pathophysiology, diagnostics, therapeutics, genetics, metabolomics, and then psychology and quality of life. So we have 300 publications, lots of contributions. We believe our sentinel contribution, and this was highlighted by Dr. Nanette Wenger at the Herrick Lecture Award at our American Heart Association meetings in 2012, that the identification and prevalence of microvascular coronary dysfunction being a key contributor to ischemic heart disease morbidity and mortality in women. This is sentinel in the sense that it previously was called cardiac syndrome X, which to us means we don't understand what it is. We now have put a name on it. The majority of the subjects with that phenotype in WISE actually have microvascular coronary dysfunction. We have estimated a prevalence using other national databases that there are 2 to 3 million women in the US, so many more in the world, with this condition. So it places it as a dominant health condition for women, for example, much larger than breast cancer in terms of prevalence and in terms of mortality and morbidity. And then last but not least, we have made inroads on, that it really does kill people. We have 10-year follow-up now that demonstrates a 20% adverse event rate that includes death, about half of which is sudden death, non-fatal myocardial infarction, non-fatal stroke, and then interesting hospitalization for heart failure. And in a retrospective chart review in a single center, these heart failure hospitalizations have preserved ejection fraction. So we believe that this is heart failure with preserved ejection fraction, which we now are calling HFpEF. And this is also a condition that predominantly impacts women. It is a now newly discovered epidemic with rising rates of morbidity, cost, and mortality. So we think that's probably our sentinel observation, is the microvascular coronary dysfunction, prevalence, significance, and that it actually does lead to adverse events that we all care about, and also cost a lot of money, cost our healthcare systems a lot of money, particularly when we don't know how to treat it. So we are 15 to 18 years into novel discovery, dominantly because we did not focus on women in the past. So we're pleased with this progress. We're pleased with the observational data that now tells us that these problems of stable and unstable ischemic heart disease in women are significant. They do kill, they do maim. We have spent the last 5 years doing what we call surrogate outcome trials, because the next step, of course, is to test interventions, both traditional interventions for ischemic heart disease and atherosclerosis, as well as novel interventions. The surrogate outcome trials that we have done include an ACE inhibitor trial and a plenarone trial, a sildenafil trial, a ranolazine trial, and a hormone trial, a low-dose hormone replacement trial. All of these trials were positive except for the hormone trial, as you might imagine. At the time, we didn't know. It was before the Women's Health Initiative came out. So these surrogate outcome trials obviously are not the same as large outcome trials where the outcome would be death, myocardial infarction, stroke, heart failure. So the next step for us is to perform large outcome trials. This is what we value the most for guidelines. We now are required, when we write guidelines, to follow our Institute of Medicine's recommendations, which is it should be evidence-based. Guidelines should be evidence-based. So to make this kind of progress now for women and ischemic heart disease, we need to design and conduct large outcome trials for the majority population that is having morbidity and mortality, most often with open arteries, with non-obstructive coronary disease. These trials haven't been done because heretofore it was considered, a good prognosis. Why would you bother to do outcome trials? And also heretofore because I believe it was women, and we haven't really valued women as much. We hope that we can appeal to our funders that this is no longer a subpopulation, and even if it remains less valuable because it's women, we certainly can deploy the cost reason. Women now are consuming the majority of the cardiovascular healthcare dollar for our insurance companies and Medicare. So this is, if we can't do it for the right reasons, we might have to do it for the economical reasons. So we'll see.
Thank you very much.
Thank you.